In this after-party video, I'm going to answer all the questions I didn't get to during this morning's live Q&A. If you'd like to hear those answers, stay tuned, because it starts right now. Thanks for learning about MS with me, Aaron Boster. I started this YouTube channel to help my own MS clinic patients learn between visits, and it's my hope that through these videos, I can help you learn too. This morning, I hosted a live Ask Me Anything MS Q&A, and I was asked some awesome questions. Unfortunately, I didn't get to answer every single question asked, so that's what this video is for. Let's jump in. Kate McGinley writes, "Hi Dr. B. Is there a chemical stage of MS before it starts to leave discernible damage on the MRI? How long does it take to show up?" Kate, that's a fantastic question, and there's been some interesting papers written only in the past couple months looking at a prodrome, or a period of time leading up to an MS diagnosis. Interestingly, that prodrome is longer leading up to a primary progressive MS diagnosis compared to relapsing MS. The prodrome really is characterized in the descriptions by very frequent medical visits for a myriad of different things. It sounds like there is something that predates the classic presentation, and I don't think we have the full understanding of what that is, but you're onto something here. It's our hope if we can get better at identifying that, maybe we can implement therapy before things even get kicked off. It's a great question. Thank you for asking it. Kimber Gill asks, "Why do I get electric shock that goes from my neck and head down the spine?" Kimber, that's a great question, and that's a super annoying MS symptom called Lhermitte's phenomenon. Now, I've done an entire video dedicated to describing this, and so I'll throw a link up above here and also down in the description below so you can check that out and learn about Lhermitte's phenomenon in MS. Brad D writes in, "Can you have a relapse if your MRI is stable and unchanged?" Now Judith writes in, "Can you have progression if your MRI is stable with no new lesions?" And so those two questions to me are really getting at the same thing. If I have clinical disease activity, but the MRI doesn't reflect it, what does that mean? And I really appreciate you guys asking those questions. The human being with multiple sclerosis may manifest disease in several different manners. They may manifest disease as a clinical attack, where they lose a discrete function, like they can't see out of their eye or their hand doesn't work. Or they can manifest disease by a progressive decline in neurological function, like not being able to walk as far before their leg gives out, or becoming weak and having increasing difficulty doing a given activity. This is progression. A person with MS can manifest activity by spots on the MRI, but here's the kicker. You don't have to have all three or two of the three in order for it to count. If you have a new clinical attack, or if you have new neurological deficits on exam, and you don't see an MRI correlate, it doesn't make it not real. It just means that all of those pieces of evidence aren't all lining up, and hey, you're not a textbook, you're a real live human. So the answer to the question is yes, you can have an MS attack that's not picked up on the MRI. MRIs are not perfect. You also can have progression of disease without seeing new spots on the MRI. The MRI is a tool, it's a biomarker, but it doesn't replace clinical presentation. Excellent questions, guys, thank you. Sugaring asks the following question. What would you recommend to choose between Limtrada and hematopoietic stem cell transplantation with aggressive presentation of MS? Thank you. Regards from Germany. That's a great question, and thank you for asking it. Now, let's unpack it a little bit. Limtrada is a therapy for MS, and it works by induction. It reboots the immune response. I have a lot of videos on this channel about Limtrada, and so you can check those out if you'd like to have more details on Limtrada. A stem cell transplant is like a hard reboot. So instead of rebooting the immune response, it ablates the immune response. It wipes out the bone marrow and it replaces it. So it's like a hard reboot. Both Limtrada and stem cell transplants are trying to reboot the immune response. And so there are some similarities, and I think it's actually a fair question. because when you're trying to look at Limtrada and compare it to something, I think the most appropriate comparison is stem cell transplantation. Now, to date, we don't have an answer to the question, but I have a colleague, a very smart professor of neurology up in Norway, who presently is doing that exact trial. He's recruiting patients with active MS, and he's randomizing them either A, to get Limtrada, or B, to get a stem cell transplant. I am delighted that he's doing this work. It's a Herculean effort, but it's going to answer that question. And so over the next couple years, I hope that we can provide a solid answer for which one works better. Theoretically, there's advantages and disadvantages to both. Helen writes in, can a medication for psoriasis that's chemically identical to dimethyl fumarate be prescribed for MS patients? Now, that's a very excellent question, Helen, and I want to unpack this question a bit. There's a drug that was tested to treat psoriasis. Now, a version of that drug, something very, very similar, has later been tested and found to work in MS. So the question is, well, heck, wouldn't one work for the other? Now, the 100% answer is we don't really know, technically speaking, because we haven't done clinical trials with that specific compound and that specific disease. And therefore, there are questions about safety, efficacy, and tolerability that you can't answer. It might be a relatively safe assumption to say that it's probably the same, but again, you can't state that with certainty. Now, interestingly, at least in the United States, there's a label that's written, and that's a recommendation. I, as a prescriber, am not bound to the label. I don't have to follow it like it's a law, but the recommendations are there for good reason, and so you at least need to give credence to them. All that being said, a prescriber has the right to prescribe something off-label. And this is something obviously that has to be worked out with an individual doctor and an individual patient in an individual point in time. But the theoretical answer to your question is it is possible one could do that. Sky Scarlet writes, hi doc, question about fecal incontinence. What are your tips or thoughts? I still walk, but I have a problem, and it's really, really stressful because I have IBS as well. Well, first of all, Sky Scarlet, that's terrible, and I'm really sorry that you're struggling with controlling bowel movements. This is actually more common in MS than people might realize. Now, I have some videos on my channel that talk about bowel control, so I'll make sure to throw a card up above and include links in the description down below. If you are really struggling and you've tried the standard stuff, the stuff that you'll find in those videos I just referenced, I want you to look into meeting with a urologist, because urologists can be uniquely good at helping with bowels, as it turns out. I also want you to look into a pelvic floor physical therapist. So those are two pro tips if the suggestions that I lay out in my other videos don't cut it. This is definitely something that you want to be talking with your MS provider about, because there's a lot that can be done to try to help. Katerina writes, how many times is suggested to see a doctor a month? And when I think about following up with the MS provider, I typically think once every 3 months or once every 6 months. That's a cadence that seems right to me. Andrea writes, good morning from Columbus, Georgia, Dr. Boster. Can a person have both MS and lupus? Would a neurologist diagnose lupus, or would another specialist diagnose lupus? Thank you so much. Well, Andrea, thank you for the question. Lupus is an autoimmune condition, and multiple sclerosis is an autoimmune condition. And we know that if a human being has one autoimmune condition, they're at increased risk of having a second. And so yes, there are situations that we see where someone has both MS and they have lupus. Now, there are specially trained doctors called rheumatologists that are experts in managing lupus. And typically when my patient has MS and lupus, they're co-managed, both by myself and by the rheumatologist. I would recommend at bare minimum being properly evaluated by a rheumatologist if I was entertaining a diagnosis of lupus. Just my 2 cents. Ashley writes, my spouse has MS. I have noticed a decline in their attitude. They've been angrier, more stressed out, and some of the previous symptoms are resurfacing. Well, Ashley, you're a care partner, and I really appreciate the fact you care so much to have participated in the live chat and to have written that question. And I want to say a few words about being a care partner. Sometimes it's a bit of a thankless job, and not often enough do we honor and recognize the fact that care partners have MS too. You have it from the outside. You're a key village member. Now you're noticing some changes in your spouse and it hurts inside. And I want to share a statistic with you. Over half of care providers, when they were polled, said that they were scared about changes in their spouse, but they were scared to say anything. And I don't want this to be a barrier for you. I really want you to do something that's brave, and I want you to reach out to your spouse and say, hey, I love you and I've noticed some things that have me scared and I want to talk to you about it. Now, that might open up a can of worms, but really your spouse may be having the same fears and they may be scared to talk to you. And so I want you to bring that olive branch forward and have that conversation. The bottom line is we want to have a village to care for MS, and you are a powerful village member. And you have a right to have your voice heard when you have concerns. And so I wish you and your spouse the very best of luck, and I hope that you can talk about this together. Divine Misery writes, muscle loss in MS, is this deconditioning or something magical MS reason? Well, Divine, you can become weak and have loss of muscle mass for multiple reasons in the setting of MS. You can actually have damage to the circuitry that runs the muscles. And so the brain message for the muscle to contract might not be fully getting there. And that can actually cause downstream the muscle to atrophy and get smaller. You can have other things that make it so that your muscles don't work properly or that you're not given proper feedback. And so there are some MS specific things that can cause weakness. The other thing that can cause weakness you addressed in your question, which is deconditioning. And oftentimes people with MS have both. They're weak because they have MS, and the MS made them deconditioned. And so we have to try to tackle both. Excellent question. Thanks for asking it. There you have it, guys. The after party. Thank you very much for tuning in to learn about MS with me. Thank you for having participated in the live stream Q&A. I'm trying to do them about once to twice a month. And thank you for watching this video where hopefully I addressed unanswered questions. If you enjoy this video, that's awesome. Please feel free to give it a like and consider subscribing to the channel. Until my next video, this is Aaron Boster saying thank you for learning about MS with me, and take care.